Okay, we're good.
All right.
Did you get? Is the sound good enough, or should we
Absolutely.
take the video off to
No, no, no.
increase the bandwidth? Or are
No,
we
no.
all right?
We're fine. We're fine.
Great.
All right. So I'll start asking you the questions. The first one is you are touted to be, in every source that I've come across over the years, the #1 spine biomechanist in the world. So are you going to be modest and say, no, not really? Or are you going to be a realist and say, I'm sorry, I have to say the truth. I am the best of the best.
What an opening question. Well, I will say that what we do here is rather unique. How about that?
All right. That's modesty. Right.
Yeah.
So you're basically into researching all the time, or do you actually get onto hospitals and help with people, help surgeons or therapists with their stuff?
Right. Well, I'm a professor at the University of Waterloo, where we have two laboratories. One is a in vitro laboratory where we take real spines, cadaveric spines, and create the injuries. We herniate discs, fracture end plates, tear ligaments, etc. In the other lab, it's what we call the in vivo laboratory, where we take real people and we have them do various tasks, and through various techniques measure the tissue loads on those structures that are at risk of becoming damaged. So that allows us to figure out the applied load, and then we know how strong the structure is. We do a stress analysis and figure out the injury mechanism that way. We also do things rather uniquely in that we measure spine stability rather than just guessing at it. Anyway, that's the scientific side. And then on the clinical side, I do see patients, usually just 1 day a week, and usually only a couple. I set aside 3 hours for the appointment. And I don't see local backs. They all fly in from various places in the world. And typically they are shall we call them the failed backs? They've already been to a dozen different clinicians. They've tried various approaches, and they didn't get better, or they were made worse. So, of course, we don't see the success stories from other people. We only see their failures. So it gives us a bit of a biased population, for sure. But having said that, we also get some of the elite performers. I know the passion of India is cricket. Well, we've seen some of the great cricket bowlers, for example. Competitors in just about every summer and Olympic sport over the years. The various American professional sports, football and basketball and ice hockey and baseball and whatnot. Anyway, that just about covers my life, and the other 2 hours a day I sleep.
All right. I just have to take a digression from something you just said. When you're talking about failed back, most of these people must be in pain, and they must be having a hard time doing their day-to-day jobs, or even something beyond the ordinary. Now, the question is, having back pain occasionally, or when you go into a heavy, unusual loading, is different, and someone living with constant back pain, as these people may be, is different. How does this constant pain change the way you treat them? How do you actually handle or overcome the fear of movement and the constant pain?
Well, that's a very thoughtful question. The basic approach that we take is we perform provocative testing. I purposefully provoke the pain and make it worse. And we'll provoke it with various postures, motions, and loads. So we define quite precisely the trigger levels of each of those three variables. Then we figure out what is tolerable in terms of motions, postures, and loads, and build a program and a method of moving, avoiding those painful triggers.
Okay, I suppose the individual issues would be specific and probably not worth discussing.
Yes, absolutely they will. Some people are overly flexible and they are bending their spines, the discs, they're stretching nerves. And the curious thing about the neurology is that if you keep stretching a painful, sensitized nerve, it makes it even more sensitive. And they will think, oh, well, we'll continue to stretch and mobilize, not realizing that they're decreasing the triggers of pain, at least the threshold triggers. And if they would stop the stretching and the mobilizing, they would increase the trigger level and be able to do more and more each day with less pain. So that might be one clinical presentation. On the other hand, you might get someone who's overly stiff and would benefit from mobility. So, you know, the answer in all of these questions, Ram, and as you're a medic yourself, the answer really is it depends on the person in front of you, and you have to adapt.
Yeah, the answer to all questions of life is it depends.
Yeah, you know, for the wise ones, yes, but there are people who will paint people like you and me as leaders, and they want to follow the leader and follow the guru, and they're waiting for the statement, you know. But it's funny when I talk to the alpha wolves like you and Pavel and all the great ones in the world. It's their disciples that are actually adamant about taking a position, whereas the real leaders respond just as you said. It depends.
In the forward flexion, you know, lumbar spine being in flexion, that article you wrote at your blog. This is about someone who says that Stuart McGill said never to flex, and I got weak and that kind of stuff. Yeah.
Right. I really avoid the internet, and I don't read all these different opinions, and a lot of the times it's some kid who lives in their mother's basement who suddenly has a forum on the internet, and they give their opinion, never having been there, never having worked with anybody. And they say these crazy things, but they never listened in the first place to understand the full breadth of the work.
Yeah, just a question that came to my mind when you talked about stretching a nerve which is already creating a problem for a given individual. Are we also referring to what people interpret as nerve flossing or nerve glides? Would this also come in there?
Well, it may do. Again, it depends. What we'll do is we will see if there is a nerve trap or compression on the nerve, and then we'll pull it from one end to traction the nerve. Now, if that causes neural symptoms, what we'll do is we'll release from the other end. So if we can get this kind of an action, another feature of nerves, particularly the spinal nerves, as they exit the center canal through the foramen, what the Japanese showed was that if you can get the nerve to mobilize or floss, it will create its own pathway. It has this ability to free itself. So it may be what we would call stiction, which is half sticky, half friction, if you know what I mean. And you can get the nerve to unstick and certainly decrease its sensitivity. And other times you really create a pathway for it to floss, and then all of a sudden movement now becomes pain-free. And the efficacy of this is, on one hand, you could create raging sciatic fire if you're not careful, as I'm sure you've witnessed. But on the other hand, if you can qualify the patient and see if you can get a little bit of flossing with no pain and qualify them for this procedure, try it for a day and see. If it doesn't make them worse, carry on. And well, I can give you an example. We had a post-surgical case where there was post-surgical scarring on the nerve roots. And it finally broke free after 3 months. The person was walking down their driveway, the adhesion let go, and the fire left their foot immediately, and they've never had it since. So what we've tried to do is enhance the various flossing procedures. So you know the one where they extend the cervical spine and then extend the knee back and forth. If you do it with both legs, this isn't from our work, but it's actually from Professor Eiraksinen in Finland. He's shown you actually get a bigger excursion if you do both legs at the same time as you move the cervical spine into extension. Or we might try a side-lying posture on the ground, etc. Anyway, that's just a little bit of a summary on flossing, and